Thank you. Good afternoon and good good evening, everyone. Tejas, can you see my slides?
Yes, sir. Your slides are visible, sir.
Perfect. Thanks. Hello, everyone. I am Dr. Rahul Mandlik from Shalina Healthcare. Welcome you all to this webinar, which is an international pediatric forum where we have experts coming from different countries like from Nigeria, Ghana, Zambia, and India. We know that all of us are trying best in coping with triple five in child care, particularly in African region. Child, this triple five is nothing but the five children below 5 years die every 5 minutes in Africa, which is as per the WHO's report published in 2013. These figures might have changed in the recent time, hopefully, but this is alarming. And the statement of hope is that two-thirds of these deaths are due to preventable reasons. And we know that there are many disorders, they become the reason for children's morbidity and mortality. Today, we are going to discuss about such three most common reasons for the children's morbidity and mortality. They are worm infestations, iron deficiency anemia, and cup disorders. Today's eminent panel are going to provide you the tips for the identification, evaluation, and treatment of these disorders. Before we proceed, I would like to introduce ourselves. Shalina Healthcare today is one of the largest pharmaceutical companies in sub-Sahara Africa. We are operating in the region from last 35 years, and since then, it is our mission of making quality and affordable medicine and to make them available across the region. And this is possible because we manufacture our medicinal products in our own WHO approved facility. Social responsibility is deeply integrated in our vision and value. Keeping this in view, we have started this initiative that is Shalina Academy. Under this banner, we have rolled out several programs, educational programs for healthcare professionals across sub-Saharan Africa, whether they are taking place through physical meeting at our learning centers, or we have also adopted this digital platform with the help of webinars like this, where we try to get international expert resources so that you get cross-learning opportunities. So with this, let me introduce our eminent panel member, Dr. Pramod Jog. Dr. Jog is a professor of pediatrics at DY Patil Medical College, Pune, India, and he is a president of Indian Academy of Pediatrics during 2016 and a steering committee member of Gavi from 2016 to 19, as well as standing committee member of International Pediatric Association during the same period. He is also a member of Pediatric COVID Task Force of Maharashtra State in India and a senior consultant to UNICEF India. He is a core committee member of National Polio Surveillance Project of WHO, UNICEF, and Government of India, and he was a coordinator of Universal Immunization Program run by WHO, UNICEF, and Indian Academy of uh, Pediatrics. So, Dr. Jog has got experience of international advocacies. One of them is UNAFSA, that is Union of National African Pediatric Societies and Associations, that was held in Abuja in 2018. And likewise, there are many other international advocacies where Dr. Jog was the part of. Sir has published more than 100 papers in national and international journals. Welcome to you, sir.
Thank you.
Our next panelist is Dr. Obong Basse. Madam is the head of pediatrics department at University of Uyo Teaching Hospital, Nigeria. She is a member of Nigerian Medical Association and Medical and Dental Consultants Association of Nigeria. She is a fellow of Postgraduate Medical College of Nigeria in Faculty of Pediatrics and also a fellow of Western African College of Physicians. She is a member of Pediatric Association of Nigeria and Medical Women Association of Nigeria. Welcome to you, ma'am.
Thank you.
Next panelist is Dr. Kantar Chandwe. Dr. Chandwe is a pediatrician at Children's Hospital in University Teaching Hospital at Lusaka in Zambia. Dr. Chandwe is researcher at Tropical Gastroenterology and Nutrition Group, that is TropGAN, and he is also a fellow of Fogarty Global Health in 2019, and he is a PhD scholar uh, of pediatrics in gastroenterology, hepatology, and nutrition. Dr. Chandwe is pediatric. He has got training in several areas related to child health care, and some of them are like he has got trained in pediatric treatment of HIV in Tanzania in 2016, in child growth assessment, in tuberculosis prevention and infection control, multidisciplinary management of gender-based violence and child abuse, and advanced pediatric life support at Advanced Life Support Group in 2014. Dr. Chandwe has published several publications in international peer-reviewed journals. Welcome to you, sir.
Thank you very much. Hello, everyone.
And next panelist is Dr. Hilda Boy. Madam is a specialist pediatrician at Department of Child Health at Korlebu Teaching Hospital in Accra, Ghana. Dr. Hilda is a vice president of Pediatric Society of Ghana. She is also president of US Ghana Alumni Association, and she is leading a project, Ghana Accra Health Bridge. She is a co-founder of JH Health Connect and Pilolo Network, and she is a fellow of Mandela Washington Fellowship in 2016, and she also played a role of president of the Mandela Washington Fellows Association of Ghana during 2019 and 20. Dr. Hilda has been awarded by Pediatric Society of Ghana for volunteerism and ambassador for newborn jaundice. Welcome to you, ma'am.
Thank you.
A very warm welcome to all panel members once again. And before I hand over to the panel, I would like to tell our audience that this is going to be a big, interesting session, and I'm sure that you will post many questions. Don't hesitate to post them on the right side box of the screen provided to post such questions and your feedback. We'll take them during question and session at the end. Now, I would like to hand over the session to the panel members. Over to you, Dr. Jog. Thank you.
Thank you. Thank you. I will just start sharing my screen. Can you all see my screen?
Yes.
Thank you. So good afternoon and good
Dr.
evening to
Joke, please put
all
it to
my friends
slideshow.
from.
Dr. Joke, please put it to slideshow.
Is it visible now? Yes.
Yes, yes, it is.
Shall I start? Thank you. Thank you. So, good afternoon and good evening to all my friends from Africa. And we are going to have a discussion where we are going to discuss about worm infestations in children, iron deficiency, anemia, and some cough and cold disorders in children. And remember that as regards the child health in the world, particularly in Africa and also in India, there are quite a few children who get sick and who die. And in Africa, an estimated 6.3 million children under 5 they died in 2013, and 2.9 million of them in the WHO African region. Okay, you know that WHO has different regions for the entire world, and the African region is a separate one. Now, two-thirds of these deaths can be attributed to preventable causes. And as Dr. Raul already mentioned, a third of all these deaths are in the neonatal period, and the major causes of death are related to the respiratory and the GI disorders, and also preterm deliveries and malaria. And one third of the childhood deaths are linked to malnutrition in the African region. So, one should know that the three topics that we are going to cover today, the worms, the iron deficiency, and the cough disorders, they are closely related to the morbidity, mainly in the area of child health. And to give some information about the worms, which in medical terms we call as helminths, they enter into our body either from the mouth or from the skin. So in case if you have water which is contaminated with the fecal matter, then the eggs, for example, the eggs of the roundworm, they enter into our gastrointestinal tract, and these eggs then hatch out into larvae and then create their manifestations. On the other hand, there are some helminths or some worms which enter into our body, like hookworm, from the skin. And if a child walks barefoot without any footwear, then these larvae usually have an entry into the body, and then they create their medical problems. Okay, these worm infestations are quite rampant in Africa, and you can see in the world map that more than 50% of areas where worm infestations are more than 50% are also seen in Africa, and definitely between 20 to 50%. You can also remember that helminths are still a concern for Africa region. While in major parts of the world, we have stopped discussing about worm infestations. In the African region, the Afrique, we have to be very, very careful about discussion. And 81.6% of the Africa region needs serious attention as regards the worm infestations as per WHO. Okay, and anemia is also prevalent in Africa to a great extent. You can see that the map, which shows dark violet color, shows that more than 60% of people in those areas have anemia. Mostly this is iron deficiency anemia related to the nutritional deficiency. And there are many causes related to iron deficiency. In addition to nutritional deficiencies, we have malaria, we have helminthic infections, and some conditions where children lose the blood by the way of some medical disorders. And obviously, we should not forget areas like pregnancy, wherein the requirement of iron also increases, and pregnant women and women in general are more prone to get iron deficiency anemia. And about the cough disorders, one should just remember that respiratory infections and recurrent respiratory infections, pertussis, they are the important causes in addition to bronchitis related to acute cough. Asthma is not necessarily an infective disorder. However, some infections can trigger an episode of asthma. Okay, so with this brief background, we will now proceed to today's discussion. And I will just stop sharing my screen. Okay. And now I will come to our esteemed panel. So I am glad to have Dr. Chandwe, Dr. Bassi, and Dr. Hilda. And Dr. Rahul has already introduced all of us in his introductory speech. So without wasting further time, we will proceed to the discussion on today's topics. And initially, I plan to discuss about the worm infestations. And then, Dr. Bassi, I would just like you to, inform our audience about the clinical situations wherein one should suspect worm infestations. So, in your experience, you must have seen quite a few children with worms. And just let us know as to when a child comes to your outpatient department, which are the children wherein you suspect that this child is likely to be having or harboring a worm infestation. Yes, Dr. Basi.
Thank you, Professor Jog. In clinical practice, the scenarios that one may suspect worm infestations in children. Firstly, it is a prevailing child health problem, so the clinician must have a high index of suspicion. Mostly, the preschool, school-age children, and even the little older children who many times play around in the environment, on barefooted, and they pick things from the environment without, so probably the improper sanitary conditions. Now, when they present in the clinic, depending on the worm, a lot of scenarios could play out. For instance, the child could display, coming with complaints of some vague abdominal symptoms like abdominal pain. This could be epigastric, periumbilical. There could be complaints of anorexia, the child is not eating well, maybe nausea, vomiting, maybe symptoms of bloating. Sometimes the abdomen may even be, distended where the worms are really quite many. Also, the child could also present with symptoms of retarded growth in the physical development, or perianal itching, where it depends on the worm, like the pinworms. The mother could complain of, especially at night. The child could be having a perianal itching, especially at night. And even diarrhea, chronic diarrhea, some could have some mucoid discharge or even bloody discharge depending on the worm's tenesmus. That is some stool disorders. So all these symptoms are commonly seen. Even if some children can present with pallor, they are anemic because if they're infested with hookworms. So the symptoms may actually depend on the worms that the child may be having. So with the high clinical index of suspicion, by the time you've asked some few questions, around these gastrointestinal symptoms and otherwise, then one could actually narrow down to suspicion of the particular worms and probably do further tests and evaluations to know.
Yeah, thank you, Dr. Base. It's a very good and an elaborate answer. And just to add to what you said, maybe sometimes the child will be totally without any symptoms, and we can have children coming with
Yes.
worms without any symptoms, while some of
Yes.
them can come with recurrent attacks of bronchitis. And sometimes in our practice, when we check their blood for some other reason, we may get sometimes the increase in the cells called eosinophils. So maybe some of them, they do have worm infestations. And then, Dr. Chandwe, I have a question for you related to quite a few parents who come to us and say that the child has abdominal pain, and the mother says that, oh, in the morning I saw a round worm in the stools. And then how would you proceed to handle such a case?
Okay. Thank you very much, Dr. Jog. And thank you, Dr. Basi, for that. As she went through some of the presentation that a child might present with who has worms. So that scenario you have presented, essentially, it's a relatively common presentation where the parents come in and say the child has been complaining of abdominal pain. Of course, we get in some instances that the child or the parents actually witnessed the passage of a roundworm. Now, when we specifically talk about roundworms, we know that amongst the worms, that's one of the commonest type of worm infestation that we get. Of course, we have most likely we're talking about Ascariasis. So this picture sounds like this is a mother and this is a child who's having worm infestation and specifically caused by Ascariasis. So if before going further, I think I would like to maybe just take a step back. I like the presentation that you made when you highlighted. There's a nice picture that you showed there where the areas that have the most worm infestations. And if you see, starting from sub-Saharan Africa, Asian subcontinent, the common theme there is these are low and middle income country laden areas. And if you take it further, what does that mean? It means most of these children are presenting in areas where there is very poor sanitation and very poor hygiene as well. So even when we talk about manifestations, actually, we have to be reminded of even the etiology or even the right life cycle of some of these worms. So specifically for the roundworm, you find that you had mentioned that this comes through ingestion of eggs in contaminated soil. So we're talking about an area where poor sanitation and hygiene. So the child ingests the eggs give rise to larva, which starts migrating through the body, and eventually it ends up in the lungs. In the lungs, from the time it moves up the lungs, then it's swallowed again, and then they continue maturing until they go back into the intestine and settle. So even some of the symptoms that Dr. Bassi was highlighting there really reflect the life cycle of this worm. So now, when they mature, of course, the child may be shedding eggs because they're producing eggs, or you can pass a live worm. And in this scenario, now this is at the point that the child now has passed a live roundworm. So it makes the diagnosis even a bit easier, but there are some challenging times where the child may just present with abdominal pain, and it's a very common presentation. So in such a scenario, taking a very thorough history is very important. We want to rule out other things that could be common, like even constipation. Of course, we know that things like peptic ulcer diseases are quite rare in that age group, but it's not impossible. So the history is very important. You rule out all these other causes. And like Dr. Bassi said, we have to have a high index of suspicion for worms, especially when we live in an area where worm infestations are endemic. So in this scenario, I would be very lucky to get a mother who has already presented and described the worm nicely. So I would say most likely we're dealing with a roundworm from there.
Thank you, Dr. Chandwe. I remember in my good old days, as you already mentioned, that the life cycle of this worm is usually 10 to 12 days. And there was really a newborn, 15 days old, who had, passed a worm, and the entire ward, it was a news there. And then in my practice, I saw a 2-month-old child passing so many worms in the fecal matter. Of course, in general, all of us know that under the age of 1 year, worm infestations are relatively less common, and then they
Yeah.
usually appear afterwards. So Dr. Hilda, I was just referring to my good old residency days when we used to see some roundworms being vomited, or some children coming with acute abdomen, very painful abdomen. So have you come across any serious presentations of these roundworms in your practice?
Not so often. There've been one or two in my practice, but not so much. Not so
Okay.
much. But like Dr. Chandwe said, we do have very serious manifestations of the roundworms. And when you explain the life cycle, we know that the lung is involved, and you could have the Loveless syndrome occurring where there's a lung abscess, there's difficulty breathing, all associated with the presence of the organism or the worm. We also could have the intestinal obstruction, which he's speaking about. In some cases, the liver can be involved, so you could have a liver abscess. For some of the children, also, you may have situations where malnutrition is what may be evident from the worm infestation that they have had. That's from the roundworm infestation. So there can be very serious complications of the roundworm infestation.
Yeah, that's
And
fine.
and I think
Maybe.
in Ghana, for example, because we have a policy where we give the anti-helminthes like every 6 months from the age of 2 years. So I'm guessing that's also a factor that affects the incidence or how often we are seeing, especially the bad cases of children with worms.
I do agree with you,
Thank you.
because the mass deworming has definitely brought down the incidence of worm infestations. I just wanted our audience to know that there are incidences where children can present with appendicitis, and the appendix, once you open the abdomen, you find some worms there, and which have produced some acute abdomen or some abdominal pain. Anyway, earlier, when we used to give some other medicines like piperazine citrate, they used to stimulate the worms, and our teachers, they used to tell us that do not use this medicine in the first 48 hours, because the worms which are stimulated will create further problem. And that's why the newer medicines like albendazole are of definitely great help in the management of worm infestations. Right. Then, Dr. Basi, there is another mother who has come to you in the OPD, and the mother is saying that this child continuously scratches around the anus, and then in the stools, I saw small moving thread-like structures. Okay, and probably she is referring to some kind of a worm. So, could you just elaborate more on this?
Thank you, Dr. Jog. Such scenarios occur from time to time in the practice where you have little children present with the perianal itching. Just means the child scratches the anus a lot, and it's usually at night because usually these worms, they migrate there usually at night to deposit larva. It can be quite irritating and very uncomfortable. When the mother presents, of course, with a high index of suspicion, you know, you would know that one is likely dealing with the pinworms. And the interesting thing is that as a child also scratches the perianal region and the mom also puts her fingers there, they get these worms also in their fingernails. The worms can also hide there and they can reinfect, themselves or other children. These worms, like you've mentioned, can also infect the beddings, clothings, and that also worsens the issue. So, with that in mind, it is very important when you're trying to treat this child, apart from giving the antihelmintic, the mother has to be told the importance of hand washing sanitary practices because, like, the fingernails must be kept low, and as much as possible, scratching around there must be avoided. And of course, if the child will also benefit from some medication that can reduce the itching, it helps so that this doesn't go on, what we call auto-infection.
Yeah, thank you, Dr. Basi. You have given the answer to the dot. And then, Dr. Hilda, I just wanted to know from you that when a school going child comes to us in the clinic and probably always walks barefoot without any footwear and looking very pale, then what do you suspect? Kindly unmute your mic, Hilda. Kindly
I'm
unmute your mic.
sorry. The
Yeah.
first thing that would run, yes, I'm sorry. The first thing that would run through my head is that the child probably has hookworm infection because of the anemia and because of the history that the child is walking barefooted. And often it may be long distances through sand where there may be the hookworms. So then they'll penetrate the skin, go into the bloodstream and cause the infection. Now, I'm not sure whether that's all you want or I should add more. So the most
No,
likely diagnosis is the hookworm infection, causing the child to have the anemia.
yeah. Yeah, you're right. And Hilda, I will just add to what you said is that the entry of these worms is from the skin, and many times you get some
Yes,
lesions around the area where from they enter. Sometimes you can get some
yes,
allergic reaction around that particular area
itching.
from them the
Yes,
worms
yes.
enter, and then when they reach the intestine, they, with the help of their apparatus, in the worm itself, they suck
Yes.
almost zero point 0.6 ml of blood per worm. Okay, so that's when they
Mhm.
together taken, it's quite a huge amount, and this leads to an occult loss of blood, and these children obviously become
Yeah.
anemic. Yeah. So we have covered
Yeah.
three important worms. One is the roundworm, second is the pinworm, and the third one is the hookworm. and Dr. Chandwe. Now, kindly tell us as to what is the drug treatment of all these worms.
Thank you very much, Dr. Jog. So when it comes to treatment, I think most of these worms have got a similar sort of life cycle. So of course, like we we're saying, some of them are ingested, some of them are going through the skin. But the treatment, generally, I can break it down into like it depends on the stage at which the infection is at. So the first scenario example I would give is in a child who is asymptomatic. So one of my colleagues has already mentioned that for some of these kids may come, they have infestation, but they're not presenting with any signs. And that's where I believe Dr. Hilda mentioned about different countries have got different national programs where they try to target these children. So you treat the asymptomatic and try to clear off infections in the community. The second uh, point where you want to treat is a patient who presents depending on the particular worm that you're focusing on. So I'll give an example of the roundworm, which are the most common. So the roundworm, you can divide that into whether this is the pulmonary stage, where the child is presenting with pulmonary symptoms like coughing, wheezing, dyspnea. So there you have to remember back, you have to take a step back and look at the life cycle and what is happening to the child. So that if the history and examination is definitely pointing to the roundworm, you may have to maybe give some symptomatic relief. We know that anti-helminth medication at that point maybe might not be very effective. And then you may have another scenario where there's a child who's presenting with predominantly GI or gastrointestinal manifestations. So this is the abdominal pain. They may be presenting with anorexia, poor appetite, even reduced activity, bloating, etc. So these are the children definitely who need anti-helminth drugs. And the most commonly used, especially for us here in Zambia, are drugs like albendazole and mebendazole. And we like this. I think even worldwide, generally, those would be like one of your first go-to drugs, and that's because mainly they've got really a very good safety profile, and they are quite efficacious. And the advantage is that for one drug, you can give it just as a one-off dose, and it will not only target, for example, common roundworms, it will also target other common worms. Because we know if this child is prone to roundworms, they will definitely be prone to other worms that are found in the soils. So these drugs have got that advantage that they target even the other worms that might not even be picked up, might have not have been picked up, maybe for example on a stool examination. So yeah, so those are the go-to the albendazoles and the bendazoles. Good safety profile, efficacy, and even compliance is good because this is not a drug they'll be taking, let's say, 4 times a day for the next 1 week. Where you get for a child, giving a child such medication, there's always a challenge. So a one-off and if efficacious, those are the ones we are running to.
Thank you, Dr. Chandwe. And then Dr. Basi, a quick answer from you about the pinworms that you mentioned. If you want to eradicate, totally remove the pinworms from the body, then to completely eradicate the worms, what is your suggestion? Would you suggest that the medication is repeated after 15 days because of the chance of auto infection that you mentioned?
It's if you want to completely eradicate the worms, it is helpful to repeat the drug because when you're giving antihelmintics, like Dr. Chanwe has said, depending on the stages, some target the larva, some target the ova, so sometimes it's helpful to repeat the drugs so that you are sure that every stage, whatever stage the worms may be in, has been reached and effectively eradicated.
Yeah, thank you. Thank you. And I will just add that, as you said, that the mother also, while dressing and undressing the child, might get infected, and she also needs to be dewormed. So the deworming medication probably for the child as well as for the family,
The whole
and
household. I agree.
yeah, yeah. That I think that will be completing the treatment of worm infestations. So with that, I must add that our audience must remember that the alphabet H in the list of alphabets is important. So helminths, these are the worms, and hygiene, there is H and H. They go hand in hand. Okay, so helminths and hygiene go hand in hand, and that's why please see that in addition to eradication of the worms with the help of medications like albendazole and bebendazole, kindly maintain a very good hygiene and do not walk barefoot. The instructions for children equally apply for adults and the pregnant women. Okay, so with that we go on to our discussion related to anemia, and maybe I will just like Dr. Hilda to be there on the screen. Somehow probably she has some problem with connection, doesn't matter. I will just tell you that children become anemic. Hilda, are you there? Very good. So, could you just tell us
Yes,
as
I'm
to
here.
wonderful?
I'm here.
So, just we wanted to listen from you as to how does a child become
Mhm.
anemic?
Okay, so for children and anemia, often you're interested in whether the production is enough, whether they're able to produce enough of the hemoglobin, red blood cells, is it enough? So, is the production enough? Then you're looking at whether there are increased losses or anything that is causing them to lose the blood that they are producing. And if we are looking at the production, we are looking at things like the nutrition. Is the child eating enough food or iron rich foods? Is the child having enough? Is the child having enough
I think Hilda has some problem with connection. Dr. Chandwe, are you able to see Hilda online or she's dropped?
Yeah, I think she's having challenges.
Okay,
Um,
doesn't matter.
yeah.
Okay. Anyway, I will just complete her answer and then we will get her back on the screen again. So maybe, whenever she was just mentioning about the nutritional deficiency. So let us imagine that there is a place where we are manufacturing certain items like a factory. So either in the factory, the raw material is deficient, like iron or folic acid or B12. So these are deficiency anemias when we are speaking about production of the RBCs. Maybe many times all this raw material is there, but people don't know how to utilize this material. And if there is some long standing infection, maybe infection of the kidney or so, then utilization of the raw material may be faulty, and that's why we get anemia in children who have some kidney disorders and others. And lastly, the raw material is available, utilization is also good, but then we said, as in case of hookworms, there is loss of blood. In some adults with ulcer disease, there is loss of blood. Sometimes there is hemorrhage, and there may be deficiency of iron because of the blood loss. So either there could be nutritional deficiency or wrong utilization or a faulty utilization or blood loss. So as relates to iron deficiency anemia, these are some of the important points one must remember. And then Dr.
Maybe
Chandwe,
just sorry,
please.
Dr. Just to jump in, not to cut you short.
Yeah,
I think just
please.
like for in our setting, and I believe this is a similar setting to places like Nigeria. In an anemic child, we always think about even congenital defects such as sickle cell anemia. So that's one thing that you have to be aware of, that there could be some congenital causes
Yeah.
maybe causing for the formation of abnormal red blood cells, which causes them to get damaged easily, and the child might present with anemia. So that's just an addition to what Dr. Hilda and yourself have talked about.
Yeah,
Yeah,
genetic
yeah, yeah.
things, genetic defects that are a bit common in the tropical areas and subtropical
Yeah.
areas.
Yeah.
Yes.
Yes, yes, yeah, and we do. Yes,
yeah.
Dr. Hilda. We have
Yes,
stolen
I'm
your
not sure
answer.
whether you mentioned the. I'm
We
Okay.
got half of
I'm not
it.
sure whether you mentioned the likes
Anyway,
of the. Apologies.
okay,
I'm not sure if
okay,
you
okay.
mentioned the likes of the sickle cell disease and all too.
Yes,
Yes,
Dr.
I'm not sure whether
Chandler
you
has
mentioned those
mentioned that.
already, but those are also common in the session. Okay, all right. And I'm sure you
Yeah.
mentioned everything else too.
No, we are coming to you,
Okay, all
Hilda.
right.
We would
Thank
like
you.
you to mention some
Pardon
points
me.
which are related to the history and the examination of a child who appears pale and anemic. So just mention the important points in the history which you would ask for, and the points in the examination would you look for in a child with anemia.
Okay, so for the history, you'd want to know the generally who the child is, the age of the child. If we know the HB electrophoresis or the genotype, sickling status of the child, is good to know. If we know the G6PD status, is good to. If we don't know, I mean, it's good to find out whether they know. A history of jaundice or recurrent illnesses is also good to know, because that may point in the direction of the child having sickle cell disease. It's good to know about the nutrition of the child, to know whether the child is able to perform activities or play well without getting easily tired or fatigued, which may indicate easy fatigability. Now, a good dietary history or the 24 dietary recall is also going to be critical. Good to know whether the child feeds from his or her own bowl or feeds with other children or other members of the family from one bowl. That helps to know the amount of food that the child actually may be getting, and the quality of the food is also quite critical in this case. Now, we know that the worms are also an issue or a problem, so it's good to know the play, how the child plays, that the child also walk barefooted quite often, or is the child like often in a clean environment. The social history is also very important, so that we'll be able to establish what the likely cause may be. Now, we need to also consider whether there's anything that's probably causing the child to have blood loss. Has there been like a big wound recently or an accident?
You got
Hello,
unmuted.
yes, sorry. So it's good to know all that. Yeah, apologies. A child interrupted me. Now, it's good to have an idea of that, so that we know what direction we may be thinking about to be the likely cause for the anemia, to capture the reduction or in the production or a problem with the production and the excessive blood loss. The color of the urine, for example, the color of the stool, is there like blood in the stool, is there darkened stool or the malina stool? It's good to have an idea of all that, because with children we have different ages for the children. We have different ages for the children, and different risk factors may pertain. So in the history we have to try to explore all that. Yeah.
Yeah,
So
thank you.
basically,
And
this should help you. Yeah.
would you like to mention about
This should
the
help
points
us.
in the examination? Yeah.
All right. So for the examination, it's good to look at the child generally, to do the anthropometry of the child, so that you know what centers the child is on or what the Z score is, whether the child is growing well or not thriving. That is good. Now, specifically for anemia, the mucous membranes are important. So the conjunctiva important, the oral mucosa important, the palms and the soles of the feet are also important. Looking there to see whether they look pale or they look normal are all going to give you clues about the level of the anemia possibly, and what may be the whatever may be accounting. Sorry, please. Yes, so we have to look at all these mucous membranes and the palms and the soles of the feet, just to examine for the anemia. And if a child is crying, for example, then for the eyes, the conjunctiva, it may not be a good reflection of what the pallor is, because then it will become very red and may look okay when it's actually because the child has been crying. So that's also something to bear in mind. Again, if it's an older child and you look at the soles of their feet, it may not be exactly like a true representative, especially for somebody who like walks often. The palm may be better than just looking at the sole of the feet. So these are some of the factors to consider in examining a child for anemia. Again, you have to look for splenomegaly, for hepatomegaly, all those, or enlarged spleen, enlarged liver, to give you clues about what the likely cause of the anemia that you have looked out for are. Thank you. I apologize for the distraction.
No, it's all right. We can understand that we are all pediatricians, and distraction by children is always going to be there.
Yeah.
Okay. Yeah, yeah. Okay, I will just add to what Hilda you mentioned. My teacher used to tell me that there are three or four things, Pramod, you must remember. Number one, if you look at the palms, there are creases. Usually, we show our hand to the
Mm,
astronauts and the astrologers, but then he used to say, don't look at the astrology part of it, look at the creases. And if there is no differentiation in the color of the creases and the
okay.
skin around the crease, then it's a very severe anemia. Number two, he used to tell me that if a child has
Okay.
pallor, if the child is pale and jaundiced, then please think of hemolytic anemia. Okay, so these two things that he always used to tell me. And of course, you have already mentioned about different points. And the third thing is, look at the child whether he is appearing sick, whether he is toxic, whether he is appearing very sick and ill, then it indicates that it's probably not iron deficiency. It is something like some, malignancy or something or the other. And as you are more
Yeah.
experienced about
Yeah.
malaria than me, maybe you can say that, Dr. Basi, you can just explain a bit about your experience about anemia in malaria.
My experience about anemia in malaria. Well, malaria is it's an endemic illness caused by the Plasmodium falciparum. There are other species, but I think that's the most common, the vivax, and the other species. But I think the falciparum and the vivax are a lot more common, ovale, and so there are very common presentations of and anemia itself is not a diagnosis. So whenever we see anemia, we must elucidate the cause. And in tropical regions, we know that malaria is very common and endemic, especially in children under 5 who haven't yet, gained the malaria immunity. So they come down with bouts of malaria that can actually affect their hemoglobin levels because the falciparum malaria and the vivax, the malaria, the parasites, they parasitize the red blood cells and leads to hemolysis, quicker hemolysis of these red blood cells. So these children coming with different levels of anemia. Sometimes the anemia may be mild, uncomplicated, just pallor, weakness, you just notice the child has malaria, and you can treat with oral iron formulations. At other times, we find that the anemia may be severe, complicated, if the child has been heavily parasitized, the hemoglobin level may actually drop so low as to warrant a blood transfusion. However, the most common presentation most times is just the uncomplicated malaria, but few times we have presentations of complicated malaria with anemia
Yeah,
in the
yeah.
practice.
Thank you, Dr. Basi. I think it was very important that you mentioned about malaria. And in a discussion in African continent, no discussion can be complete without mention of malaria. Thank you. So now, Dr. Chandwe, I would like you to tell us that there is a child who is anemic. We have taken the history, we have examined the child. Now, the pediatrician is interested to know as to whether it is the deficiency of iron which is responsible for anemia or whether it is something else. So in brief, how can you tell our audience that it is deficiency of iron and nothing else which is producing anemia?
Thank you very much, Dr. Jog. Um, I think when in narrowing down the causes of the anemia, Dr. Hilda talked about the pertinent history and the examination that you need to get. And I think an important detailed history, just like in any pediatric condition, is paramount to making a diagnosis. So knowing that this is anemia secondary to iron deficiency begins from there. The examination will also, of course, collaborate and rule out other things, but then we will have a very high index of suspicion. And of course, we do investigation to confirm what we have picked up on the history and examination. And one of the things that we can do in most centers is a simple full blood count or a complete blood count. And from that, of course, we'll confirm by looking at the HP. We'll look at the hematocrit as well, and those definitely will tell us the child is anemic. But in addition to that, we want to classify what type of anemia is this based on the size of the red blood cells. So the full blood count will give us an index called the MCV. So the MCV is essentially telling us the size of the red blood cells. So we can have, yes, we have seen from the hemoglobin and hematocrit that this is anemia, and then we go and look at the sizes of the red blood cells, then it will tell us whether this is a microcytic, is it a normocytic, or is it a macrocytic anemia. So those will be like the some of the outcomes. And then for iron deficiency, we know that it gives a microcytic picture. So the red blood cells will be smaller than what you would expect for that age of the child. So it presents with a microcytic anemia. But other clues on the full blood count as well, we want to look at, maybe you want to rule out other things. We're looking at the reticulocyte count just to make sure that this bone marrow is working well. So it's trying to compensate for that anemia. So it's overworking and the reticulocyte count starts going up. In addition, just on the full blood count, we can also look at the RDW, red cell distribution width. So what that tells us, if it's, for example, we want to differentiate whether this anemia is iron deficiency, nutritional anemia, or is it a congenital problem like the thalassemias, the sickle cell. So that RDW, we know that it increases very much in nutritional anemias. And there's also a reactive thrombocytosis, meaning the platelet count will be able to pick up from the full blood count that it's raised. And this is because the bone marrow is trying to work very hard to replace or to overcome the anemia. But in the process, it also produces a lot of platelets. So you get a thrombocytosis. So those are some of the clues that we pick up on a full blood count. And in addition, if we put that with the history and the examination, it would definitely point to an iron deficiency. But if the things are not clear, we can even move forward and do things like peripheral smear. On the peripheral smear, we'll see again that these are small cells, microcytosis. We'll also see that they are very pale. They are hypochromic. And of course, because of the different sizes, we may see that there's anisocytosis, which again will suggest a nutritional deficiency as opposed to anything else. If that doesn't conclude, rarely we may start, again now we may go on to do iron studies. So we want to see what's the iron status in the body, and one of the best indicators of that is, of course, doing a ferritin level. So those are some of the ways we'll be able to confirm that this anemia is caused by iron deficiency.
Thank you, Dr. Chandwe. I always remember my old teacher who used to tell me that a child who is malnourished and pale, the RBCs also are a reflection of the child. So the RBC is also small and pale. That is microcytic and hypochromic Pramod. So remember, the RBC is also malnourished and pale. Okay.
That's a
So
good way
that's
of
all.
remembering it.
Yeah. Okay. We will now proceed. Dr. Basi, please tell us some food items which are rich in iron so that our listeners would know as to what should be included in the food so that children do not become iron deficient.
Okay, thank you, Dr. Jog. A lot of food items are rich in iron, but well, let's discuss it by, I use the animal sources that are rich in iron, the plant-based sources, and others. And I'll just mention the common ones, though there are many, but to mention but a few. The animal-based sources of iron include the poultry products, the fish, different types of fish, different types of beef. We also have the dairy products like egg, milk, cheese that are all rich in protein. Some seafoods too are highly proteinous, like the crayfish, the shrimps, oysters, crab shells, the periwinkle. There are some simple things like the periwinkle that are quite affordable. These are also rich iron sources. The plant-based sources include the cereals, some staple cereals like the beans, either the brown beans, the white beans, whatever, are also good sources of iron. The green leafy vegetables, it differs from country to country, but I mean, like in Nigeria, you have the pumpkin, which is very, it's very quite common. It's very rich. In fact, there are some people who, in trying to, I think it's some of the local practices, they actually squeeze pumpkin leaves to drink, hoping to, because you see, when you try to get iron from the vegetable sources. One other important thing to note is that apart from the iron, another like folate and vitamin B12 and other things that are also rich in these vegetables, prolonged cooking can destroy some of this and it can affect the delivery of iron. So most of the times, vegetables that can be eaten raw are best eaten raw. For those that are to be cooked, one has to be sure that they are not overcooked, such that the nutrients are killed, so that the nutrients still remain fresh and available for the body absorption. Okay, for the vegetarians, you also remember you could have a liver, that's and a good source of iron. The liver of different animals are good sources of iron, and also like the dairy products, these are all highly proteinous foods. There are many others, but just to mention a few common
Thank you.
ones.
Thank you. Thank you. And then maybe, as I was just talking to you earlier, squeezing a lemon in the food items, it's my personal, practice. I usually keep a glass of water and a fresh lemon squeezed into that. So vitamin C is automatically entering into system, and it is known that we are able to enhance the iron absorption with vitamin C. Of course, I can understand it's more for the adults, and it all depends on the likes and dislikes of a child. Doesn't matter. Dr. Hilda, please tell us
Yes, but
some.
if you have, yeah, I
Yeah.
was going to say that if you want to include, maybe for the kids, you could give them some snacks like you can give them fruits. You can give them fruits, and that will give them the added vitamin C that they need to help with the absorption of the
Yes.
iron. It doesn't necessarily have to
Yeah.
be lemon, which I'm sure they'll find star, but any of the
Okay.
will work.
Yeah. Yeah.
I don't know
I
whether she
think,
mentioned the liver. The liver.
yeah,
Liver is
she
also
mentioned.
a very good
Yeah.
source. Okay, all right.
Yeah, she did.
Okay, thank
Okay,
you.
Hilda,
All right.
in you can just mention about how you manage a child whose hemoglobin has dropped to 8 grams %. A quick answer from you. How would you manage the broad principles?
Okay. All right. So I think the general principle, if this is not a child who is, let's say, deteriorating, or there's the cardiopulmonary system is not stable, and the child is stable, but the HB is just low, the 8 gram per deciliter, what you could do is to give elemental iron aside the dietary modification or the support in the diet. So the dietary modification can be done iron rich foods, like she has mentioned, Dr. Abasi has mentioned, much encouraged. The dietitian can also come in to show them exactly what to take, how many times, how often. That can be done. But aside that, they could be put on elemental iron. The usual recommendation by the BNF, about 4 to 6 gram per kilo per day. So depending on the weight of the child, that measurement is done, and that is given to the child daily. And monitoring is done. The full blood counts, the reticulocyte counts can be monitored monthly or so to see how the progress is. And it's important that for children, we don't, it's not one size fits all. So the dose of the iron is not one size for every child. You need to know the weight of the child so that you can do the calculation before you give the child the exact dose of iron that you are giving to them, aside the food that is recommended, and the vitamin C in the fruits and the vegetables that they are getting, because those will also help with the iron absorption. Again, you have to check what caused the child to become have the deficiency anemia or the anemia in the first place. Once you know the cause, to you have to try and remove that cause if possible. If not possible, you manage whatever brought the iron deficiency anemia or the anemia on. If it's the helminths, you treat. If it is the nutritional, definitely. If it's sickle cell or other things, you manage. If there's bleeding, you try and find where the source is and you try and treat it. So these are the principles that I would like to share. Thank
Thank
you.
you. And Dr. Basi, please tell us something about sodium ferritate, which is a salt used for the treatment of iron deficiency anemia.
Okay, thank you. Sodium ferritate, well, I will say that it's one of the newer conventional iron, oral iron salts that being advocated. You know, the older conventional ones that we know are that these ferrous sulfates, the ferrous fumarate, ferrous gluconate, but the older conventional ones that we know have their limitations in terms of absorption, and many of the foods that we eat contain iron absorption inhibitors that the older conventional salts are affected by. Sodium ferritate is a newer oral iron formulation that seems to have some advantages over the older ones. For instance, it is not affected by iron absorption inhibitors that are found in many foods that are very common to us, like the tannins, the phytates. The sodium ferritate is more water soluble. It's more absorbable, in the gastrointestinal tract. It's more tolerable. Then, it also it's devoid of metallic tests, that can occur when some of the older salts are being used to fortify cereals. Sodium ferritate doesn't have the metallic test. And we have also seen that at the same dosage or even the lower dosage of sodium ferritate, you find out that it gives a higher, because of the higher absorption rate, it gives higher values in the hemoglobin when used, which is, of better advantage than the older conventional salts. So the WHO is now, is now advocating that sodium ferritate, a new oral iron therapy, is very helpful in the treatment of iron deficiency anemia.
Yeah, yeah, and very rightly said that it has less of the gastrointestinal side effects and devoid of the metallic taste, and probably produces less of the staining of the teeth. Anyway, with all that, thank you, Dr. Basi. Dr. Chandwe, please tell us about some other ingredients which are added to the iron syrups. We know that we have folic acid, we have B12, we have vitamin C, we have zinc, and what is the role of all these other items which are seen in the iron syrup?
Thank you, Dr. Jog. I think these other elements that are added to syrups have to do with the fact that when you diagnose a child with, for example, nutritional anemia, i.e., iron deficiency anemia, we have to remember that yes, they are lacking in iron. So all those foodstuffs that have been mentioned, maybe they are lacking in their diet. But we also have to remember that those foodstuffs also deliver other things. They need to deliver vitamins. They need to deliver minerals. So if this child is deficient in iron because they're not eating enough, then we can safely assume that they're also deficient in other micronutrients. And specifically speaking, some of the major deficiencies, especially in low and middle income countries, are things like zinc. So zinc comes in, it has a role to play in that. You need it for a lot of processes in the body. It's very important. And when you talk about vitamin C, I think one of my colleagues has already mentioned that vitamin C enhances the absorption of iron. So if the child is taking in iron and at the same time they're also taking in vitamin C, there are some complexes that are formed which make it easier for the iron to be absorbed. So even or the dose, we know that just like any medication, not everything would be absorbed. But in the presence of vitamin C, most we know that we have a higher absorption of the iron. And so other deficiencies that can come in with the nutrition, of course, are things like vitamin B12 and folate. And we know that those are equally important in the formation of red blood cells. Of course, they have other vital functions in the body, but those are some of the core nutrients that can be in a deficient state. So they help as you are treating the iron deficiency.
Okay. Thank you. Thank you, Dr. Chandwe. We have some more questions on anemia, and we will take them up in the question answer session. But for the time being, we will proceed to the discussion on the cough and the cold part of today's discussion. And Dr. Basi, I will like you to tell us as to how would you approach if there is a child in your OPD coming with cough and cold only for one day. It's only that child has had cough and cold for a day and mother has approached you for further treatment. So what are your views on the management of this common scenario?
Thank you, Dr. Jog. Cough and cold is quite a common presenting symptom in the children outpatient departments. And actually, most of the time we can say that every child or most children will have up to maybe about 6 to 8 episodes of cold cough every year, you know, because you see it's the seasonal changes, maybe the dust, and maybe daycare, the pre-nursery or the preschool, school age children interacting with themselves. So for a mother presenting with cough and cold of 1 day duration, first and foremost is to reassure her that it's a common symptom and there's no need to be too anxious. It could be, just an allergic cough. It could be due to viral, some viruses. So what I would just do after reassuring the mother is just to examine the child. If if the child has maybe some low-grade fever, the child will benefit from some antipyretics, and it would be good to advise adequate hydration fluids for such a child. It's important, and to continue good nutrition. There may be no need for any cough medicine at this time. That's just to reassure and ensure that the child
Yeah, thank
has
you.
the basic.
And I'm sure the child also doesn't need any antibiotics at this moment because
No.
it appears to be more like viral. And again, whenever there is a viral infection, more than one system is involved. Like the same child who has cold and cough will have, redness of the eye, and some of them could have loose motions and rash. So more than one system is involved. Usually we say it's viral. While in case of tonsillitis and pneumonia, only that part of the respiratory system is involved. So that's more like bacterial. And obviously, children with bacterial infections are more toxic. Anyway, Dr. Chandwe, a similar child has come to the OPD who also has cough and cold, but on examination, he has wheezing. Okay, the mother says there is a wheezing sound which is coming out from the chest. You also confirm it on auscultation. So, are there any additional points in the management of such a child who has received antibiotics, maybe antihistaminics? Would you like to give anything more?
So I think I'd like to pick up from where Dr. Basi left off. So as she correctly put it, most of these coughs that we see in children under the age of 5 are probably viral induced or things like allergic rhinitis. and by and large, most of them will just not so many medications are needed. But one of the components during that explanation to the parents, we are reassuring the parents, and of course, if there are any symptoms that are what I can say disturbing the child. So, for example, the child is having an excessively runny nose. Maybe the cough is disturbing the child, and we know that most of the coughs in this kind of scenario will be what is called a post-nasal drip. So you might want to give some relief, like the antihistamines and maybe decongestants, what so on. But we have to be very careful with prescribing things like the cough suppressants, etc. But in this scenario where, in addition, they have a wheeze, I would be probably thinking this is a viral-induced wheeze, and of course the history would have ruled out things like this being an asthma. And if I think this is a viral induced wheeze, this is a child who probably may benefit from a bronchodilator.
Okay, that's great. As you rightly said, one has to be careful while giving antihistaminics. And Hilda, I'm coming to you now, and I would like you to tell us in brief about the different types of
Mhm.
cough syrups which you feel are useful in your practice.
So there are generally two different types. We have the expectorants and then we have the cough suppressants. Now, those that are the expectorants, they help to thin the mucus in the airway so that whenever you cough, it makes it easier for it to come out. And this is very useful in situations where there's a lot of secretions or there's a lot of mucus that needs to be thinned to come out. Now, the suppressants are used when there's a dry cough which is disturbing, and you will use this, or I will use this when I have sort of ruled out other serious causes of the cough. So I know that this is not, I've done my investigations and I know that I'm not dealing with, let's say, tuberculosis, for instance, or something more serious than just like a dry cough. So then that becomes useful. So generally, two different types. And in children, we are not often in a rush to give a cough syrup. You are rather in a rush to find out what may be the underlying cause of the cough. Once you find that, then the decision can be taken about whether really the child needs a cough suppressant or whether the child needs an expectorant.
Yeah,
Thank
thank you.
you.
Thank you. Actually, what I have done is on my table, I have a list of all these cough syrups, and I have written the components like diphenhydramine, then
Mm,
ammonium chloride, then the
mm,
promethazine, and then salbutamol and guaifenesin and all. And I have written the exact composition in each of these cough syrups, so that I know when I look at the child, I write it that this is the component which I need to give to the child. And particularly for a child who has very dry cough at night, which is
mm,
disturbing his
mm,
sleep, I use the
mm.
cough suppressants, provided otherwise the
Yeah,
child is fine. Because many times
yeah,
the sleep of the child gets disturbed, and the
yes.
entire next day is wasted in sleeping. And in fact, sometimes I have to give some sedative to the parents also, because otherwise they keep calling me at night. And sometimes, anyway, yeah, right. So with that, we have discussed quite a few points about worms and iron deficiency anemia and cough and cold medications. And there is something which I wanted to know all from you, that vitamin C has been of late being given by quite a few physicians, particularly as an immune booster and an antioxidant, because this pandemic of COVID was around, and the vitamin
Mm.
C use has definitely increased. So maybe in a sentence or two from each of you, I would like to know as to where all do you prefer vitamin C. So Dr. Chandwe, I will start from you as to what are the areas where you use vitamin C. So you can be frank about it, no problem.
Okay, I think for me in my practice as a standalone, because my bias is towards nutrition, so I deal with a lot of with kids who have different forms of malnutrition. So we really try to keep away from this so let me start with multivitamin supplementation, because you want to teach the mother how to feed, how the baby should get all these nutrients from a well-balanced diet. So the focus is on the diet, teaching mom what to feed. But the few instances where I would prescribe vitamin E, of course, in um, in a child who I know is at risk of having these prolonged symptoms in terms of a flu, or indeed somebody who's had a prolonged period of flu. So I would give that. Uh, Essentially, of course, it's not that it might cure the viral cause of the flu, but we know because of its effects on the immune system that it might maybe reduce the symptoms and also alleviate the symptoms faster. So that's one of the areas I might have to prescribe it.
Yeah, thank you, Dr. Chandwe. Dr. Basi, how about you? Where do you use vitamin C?
Well, I do prescribe vitamin C from time to time in children because we know it's an antioxidant, so like Dr. Chandwe has rightly said, an immune booster. So for a child who has the flu, maybe I have the viral, flu, I would give vitamin C for maybe a fortnight or a little more. It may not necessarily be so prolonged as maybe the whole year through, but it could also be helpful. I also like to use vitamin C if I have to give a child an oral iron formulation, and I'd like to prescribe alongside with vitamin C because I know it aids oral iron absorption. And of course, with the COVID-19 pandemic, one can't go wrong with using vitamin C from time to time because it's known to be, an immune booster. So it is helpful in these scenarios.
Thank you. And Dr. Hilda, how about you?
I,
Where
I
all do
agree
you?
with what they've all said. I agree with what they've all said, but just to also add that a child who has burns or has wounds or 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 has ulcers that is recovering, I would give vitamin C. Again, if the child has scurvy, then definitely vitamin C is also the way to go. So I agree with all of them, and I've added just these.
Okay, thank you. I personally, in my practice, I use vitamin C whenever, as we discussed about iron deficiency anemia, I make it a point that the child receives that. And we had quite a few serious cases of COVID-19 where we had to give vitamin C in mega doses, mega meaning thereby 1 gram, 2 gram, or 3 grams, because it is known that vitamin C in high doses helps. In these children who are really sick, and more the severity of the illness, more is the dose of vitamin C required. That is the fact which all our listeners should remember. Otherwise, daily requirement is not more than 100 milligrams, and we can all get it from one orange a day. Okay, that's fine. Okay, so before we say au revoir, we have Dr. Rahul, who would be joining us for a minute. And Dr. Rahul, if there are any pressing questions from the audience, please let us
Yeah.
know so that we can go ahead and discuss some of the other remaining issues. Thank you.
Thank you so much, Dr. Jog, and thanks to the panel members for such a wonderful and interactive session. You have taken all the questions so nicely, and I could notice that there are multiple insights coming on the same point from all the panel members. Thank you so much. So, I would like to take a few questions. Please allow me to take some questions asked by the audience. First question, which goes into Helmin's side, that is the role of X-ray in the detection of worm infestations. So, which are the type of worm infestations where X-rays are generally used?
Yeah.
Maybe I can pick that up.
Yeah.
So X-rays we rarely use them in trying to diagnose worm infestation. They might come in where we have a complication. So this is a child who may present with severe infestation, and maybe they have had a bowl of worms that have caused intestinal obstruction. So the primary issue of ordering an X-ray really is not to diagnose that they have worms, but maybe to confirm the intestinal obstruction. So you want to see maybe fluid, gas levels, and etc. So maybe at that point, that's when you would request an X-ray. But as a routine for diagnosis, that's not really routine.
Right. And maybe, Rahul, in occasional cases where the certain different types of worms, they produce some problem in the brain where we call it as neurocysticercosis, which is totally a domain of pediatricians and neurologists, where we need
Yeah.
more of a CT scan or an MRI. But I fully
Okay.
agree with Dr. Chandwe that mainly to detect the intestinal obstruction, where we can get multiple fluid levels, and then we can detect the complication. Thank you.
Perfect. I will move on to the next question now. What would be the best treatment for sinusitis in children?
Yeah, actually, I will take it up, Rahul.
Yeah.
I will just like to, mention that in children, sinusitis is most commonly bacterial, okay, as opposed to the tonsillopharyngitis, which is in 70% cases is viral. Sinusitis is not to be taken as viral, and almost
Okay.
all the cases of sinusitis and otitis media, that is middle ear infection, are usually taken as bacterial. And management no doubt includes antibiotics, okay, and amoxicillin is the drug of choice at our end. And in case if you find that the sinusitis has been going on for a long time, like a month or so, then many times we have to add what is called clavulanic acid, that is amoxicillin clavulanic acid. Of course, that's the arena of a pediatrician. And anytime whenever you get a child with sinusitis, the consultation with the ENT surgeon is a must, because the entire upper respiratory tract needs to be evaluated. But essentially, the treatment involves antibiotics along with antihistaminics, and in case of fever, antipyretics. Of course, there are different grades of sinusitis like mild, moderate, and severe, and probably that is beyond the purview of today's discussion. Thanks.
Okay. Next question is from anemia side, and we have Dr. Kerry asking this: how does adding milk to porridge impact iron absorption?
Dr. Basi, you can take it up.
What is, sorry, let me hear the question again.
Yeah. How does adding milk to porridge impact iron absorption?
Okay, adding milk impairing iron absorption has to do with, the iron absorption inhibitors that are present because milk, there are some things that aid iron absorption, like vitamin C, like we said, and there are other things, there's other components of food that can inhibit iron absorption. So milk is one of them, and some calcium containing, foods. There are other things that could inhibit iron absorption. So it's best to actually use things that would aid the iron absorption than things that would serve as iron absorption inhibitors, because they would reduce the bioavailability of the iron when taken.
Okay. Uh, Moving on to the next question, that in which type of worm infestations expulsion of worms from the mouth is commonly seen?
Yeah, it's of course, obviously, it's the roundworms.
Can I
And
just respond? Yeah.
please.
Yeah.
Yeah, so when the roundworms during their life cycle, when they reach the area of the throat, then at that particular juncture, in fact, during the days of my residency, I had seen a child who came gasping, literally very serious. And when we examined the throat, there was really a roundworm which was seen by our naked eye, and that was creating the problem. And of course, these scenarios now have gone down with the advent of anthelmintics, and also the national campaigns of mass deworming. That's, in a way, it's a good thing. Yeah.
Yeah, Dr. Hilda, you were saying something.
A few times when, yes, there are a few times when it may even come through the nose as well. So not just the mouth, the nose as well. But like Dr. Jog said, it's not so common anymore, but those are possible presentations.
as well as the anus.
Yeah, right. So, uh, in regarding the treatment part, albendazole has to be taken with food or before food. What time is the good time actually to take albendazole?
Yes, Dr. Chandwe, would you like to respond?
Uh, I think if I remember correctly, it's just the advice we usually give is just before food, or maybe 2 hours or so after food. I don't know if that's specific to the benders or benders, or maybe my other colleagues can chip in on that.
Well, I think the albendazole is best taken when the tummy is not too full, so maybe just before food or about 2 hours after food. Don't know if Dr. Hilda has anything to add from her practice.
No, nothing. Thank you.
Right. I will just move on to next question. Which dermatological symptoms are seen during larva penetration?
Yeah. As I said during the discussion of hookworms, usually there is allergic reaction around the place from where the larva enters. That is one. Secondly, in case of the pinworms, that is the E. vermicularis, we have perianal itching, that is pruritus ani. And in girls, what we get is vulvovaginitis. That means there is also involvement of the area of the vulva and the vagina. Particularly, this is true for pinworms, that is the E. vermicularis, the one that Basi described, where we get auto infection and so on and so forth. So these are some of the skin related features. Of course, there are some other worms wherein we do get skin manifestations, which we have not discussed today. But then sometimes we get urticarial rash in a worm called strongyloidosis, which is not very common. But then there are different worms which do produce some skin related features.
Right.
Excuse me.
Any point from other panelists on this question?
Well,
Yeah, I
maybe
think
at the point at which the worms pierce the skin, there could be a lot of itching, maybe redness around the skin, and maybe depending, slight swelling around that point.
Yeah, yeah,
That's what the patient may notice.
yeah. And
yeah, and
the medical term which is used is called ground itch. It is called as
yeah.
ground itch.
Around itch, yes.
Yeah, and this is usually classically we see that in maybe not so much in the very young ones, but the adolescents and even of course adults. And this is mainly because of let's say maybe the nature of their work, walking barefoot. Maybe they're in the fields, plowing the fields, working in the field. So the main locate it's you look at the age, and also the main location will be like in the feet. So they will get that ground itch where the worm penetrated.
Right. Okay, I will move on to next question now. We just have very few questions left. Uh, what is the generally recommended duration of iron supplement in case of children? Oral iron supplement.
Yes, Dr.
For
Hilda, can you
the,
take
can
this?
I,
Okay.
okay, all right. So for the oral iron supplementation, we'll usually do for a minimum of about 3 months, but we could do much more. And your stop time will depend on what you find when you do the monthly follow-ups of the full blood count, the reticulocyte count, and the other parameters if needed. So a minimum of about 3 months, but you could go much further because it takes a while before the hemoglobin will build up, the red blood cells will build up for you to get a higher or a rise in the hemoglobin. So it's not instant like blood. So a week will be what many think you need to do for a minimum of about 3 months. Thank you.
Yeah.
Dr. Basi or anyone, if you want to add on.
Yeah. So no, I think yeah,
No.
that's correct. That's what we usually do as
Oh
well. So
God.
if you think that we talked about investigations and routinely we don't do like the iron studies and the, for example, the peripheral smear. So one thing that actually confirms the iron deficiency is when you start these iron supplementation. For example, maybe after 2 weeks or maybe at the month, when you repeat the full blood count, you will see that the hemoglobin and all those indices that Dr. Hill is talking about are improving. That is actually another way of confirming, even without doing the iron indices, the iron serum iron levels that I mentioned. So that will give you a confirmation that yes, you made the right diagnosis and the treatment is working. And then you stretch it out now to 3 months or more.
Right, Dr. Chandwe.
Yeah.
So now I will move on to next, and that is the last question, which I will take up from the audience, which is about the constipation. What would be the best treatment for constipation in children?
Okay.
May I just say a few things? So the best treatment, you have to first of all look at what the potential cause is. What is causing the child to have constipation? Is it because the child is not eating food that is rich in fiber, is not taking enough water? Is there a functional problem? Is there a neurological problem? Is there, let's say, maybe depression, anxiety? Are there any of those? So then once you know what is causing it, it's easy to handle. If it is because they are not having enough fruits or fiber or in their meals, then the increased fiber in their meals is good. Enough water, they should take enough water a day, not less than their minimum requirements for the day or even more. And for children, when it comes to their fluid requirements, again, it depends on the age and the weight of the child, so then that needs to be calculated as well. You also look at exercise. Is the child moving enough? Because if this is somebody who is not moving, then it's possible that the constipation may be as a result of that. Is it because of medication that the child is taking? If the child is on medication like morphine, then we expect constipation to be a side effect. And there we may give something like lactulose to help with the bowel movements. Now, the other factors, is it something like Hirschsprung's disease? Has the child had surgery? All those things need to be looked at. Is it because the child is lacking certain what do I even say? I'm talking about the electro. Is there something, an imbalance somewhere? All those things need to be looked at so that once we find the exact diagnosis, then the treatment can be made. So it's not a one-off something. You may just symptomatically treat, but if you don't tackle the root cause, it will recur or it will continue to be a problem, and you may have the complications of the constipation also occurring. Some may end up having fissures also. So simple answer, find what the cause is and treat. But usually we know that it's because probably they are taking foods that is low in fiber or not drinking enough. So you tackle those and you look out for the other things that may be predisposing or causing the child to have it, and you manage appropriately. Call for help if you are not sure. You could see the child could be made to see a pediatric gastroenterologist if needed. But there are varied causes and they need to be looked into. Thank you.
Yeah.
Yeah, maybe
Thank you.
just if I can add on what Dr. Hilda said,
Yeah.
I would like to share our experience here. So we have like a GI clinic, and in that GI clinic, that's where we see most children with recurrent abdominal pain. And if we just take that group of children with abdominal pain, I can safely say at least three quarters of those are because of constipation. And just like Dr. Hilda said, once you take a history, you want to find out an organic cause, and you have ruled out all these things like congenital, your Hirschsprungs, and then you boil it down to a functional constipation. So most of those will be functional constipation, and so it's all about keeping the general advice will tend towards keeping the child active, eating the right food in terms of fiber, taking enough fluids. So that would be like I always tell parents like that is the main treatment is the diet change, lifestyle modification. But of course, if they're coming at a point where the child, maybe the stools are really laden with stool, you might want to disimpact. So you give a disimpaction therapy, which may include laxatives and so forth, and then you may give them some maintenance. But at the end of the day, lifestyle modification and diet would be the backbone of the constipation treatment. And this is usually a prolonged treatment. Most parents get frustrated. They'll say when they come back, maybe they say after 3 weeks, they say, no, they still abdominal pain. But at the onset, we always usually explain to them that this will be a prolonged treatment. Yes, there'll be some improvement, but it will take some time for the child to start going to the toilet well and the pain to completely go.
Yeah, correct. And then, Rahul, I will just tell you that the management includes three D's. D. One is the diet, second is the discipline, and third one is the drug. That summarizes the management of constipation. Three D's. Yes.
Right, sir.
I agree with you. It simplifies it.
I
Yes.
like how you simplify.
Great. So these are the questions actually. I have taken most of the questions from the audience. I have filtered off the questions which you already have covered during the discussion. And I would like to pass on our sincere thanks to the entire panel members, Dr. Joe, Dr. Chandwe, Dr. Hilda, Dr. Basi. Thank you so much for being so energetic and enthusiastic in passing on your experience and learning, which is going to act as a very good guiding tool and tips for our audience. Thank you so much once again. I will also like to pass on our sincere thanks to our audience who is constantly supporting to these programs. And I would also like to pass on thanks to the professional bodies. They have provided CPD CME points accreditation to this panel discussion. Thank you.
Okay. Right. Thank you, Dr.
Thank
Chandwe,
you.
Dr. Basi, Dr.
Thank
Hilda,
you
Dr.
for
Rahul.
hosting me.
Au revoir. Au revoir. Okay.
Thank you very much.
Thanks.
Thank
Au
you.
revoir. Have your Bye bye.
Bye.
Thank you.
Bye.
Bye.